Hello, ladies and gentlemen. Welcome back to our last lecture in our series of lectures on anesthesiology. In this lecture, I'm going to delve back into my memory banks a little bit and tell you something of the evolution of anesthesiology during my nearly 40 years in this specialty. Then we're going to discuss what I see as being future areas of development in anesthesiology and my own personal vision of perioperative medicine and how it may evolve. So the last 40 years, since I've been an anesthesiologist, there have been dramatic changes in our specialty. One of the most important has been a change in the behavior of the people working in the operating room. When I started anesthesiology as a resident way back in the 1970s, the surgeon was a god. Behavior by the surgeon was often extraordinarily inappropriate, throwing instruments, temper tantrums, very bad jokes, trying to get the nurses embarrassed or laughing, or in some cases crying. It was very manipulative, and there was often a war between the anesthesiologist and the surgeon. This has changed dramatically. It's partly because hospitals and hospital systems will no longer allow this kind of behavior. It's partly because nursing personnel have become more assertive and more sure of their own rights, and it's partly because the relationship between surgeons and anesthesiologists has improved dramatically in collegiality. There's now a real appreciation of the skills that we all bring to the team, and the team is a very important part of the system that acts to provide surgery to patients. The surgeon, of course, is still a vital part of that team. And the system is set up to support the surgeon. And that is not going to change, nor should it change. There needs to be assistance to the surgeon at all points in the operation. However, the skills that the nurses bring to the table are really phenomenal. In an orthopedic procedure, such as a total hip replacement or a total knee replacement, there are literally hundreds of pieces of equipment that the scrub nurse has to keep track of and provide to the surgeon at exactly the right moment. It's really an amazing dance that occurs. And there's great respect now between scrub nurses and the surgeons they work with. The circulating nurse operates, or basically runs the whole operating room. It's the circulating nurse's duty to bring equipment in, to take equipment out, to provide information to the waiting areas as to when surgery will be done, to notify the recovery room when a patient is ready to go there, to notify the holding area when it's nearly time for a patient to come from there for the start of surgery. They provide a great deal of support to the anesthesiologist in terms of providing us with the pieces of equipment we need, particularly when things are challenging, such as in a difficult airway situation. The operating room is a great place to work. It's clean, it's air-conditioned, the teamwork involved is tremendous. And working with a bunch of professionals, each of whom knows his or her own job in real detail, is a real treat. The only negative thing about it is you have to wear a mask, and they get to be a bit smelly after a while. But that's a pretty minor complaint in the bigger picture. Things that have changed in other ways during that period of time have been our care of patients. The biggest revolution that occurred during the time I've been an anesthesiologist is the introduction of pulse oximetry in the early 90s. It absolutely revolutionized our care of patients. We went from a point where the only way we knew things were going badly was if the patient's color changed. In other words, they became bluish, cyanotic. When that happened, it usually meant we had less than a minute to figure out what was going on and correct it before the patient arrested. With pulse oximetry, we know way in advance if there's a problem, and we can work on dealing with it well in advance of any crisis. The result of that has been a marked decrease in the numbers of operating room deaths. The second big introduction was the introduction of end-tidal carbon dioxide. For the first time, we knew exactly how we were ventilating our patients. We knew exactly whether we were ventilating too much, too little. We knew what pressures we were using. But most importantly, we knew what minute ventilation was producing the correct acid-base balance for our patient in terms of their end-tidal CO2. This was a very important change as well. Other changes that have occurred, although not quite as dramatic, have also been extremely important. The fiber optic bronchoscope has been available for many years, but it only became small enough to put through endotracheal tubes in the 1990s. And it wasn't until the 1990s that awake intubation became something that every anesthesiologist should be able to do with skill and with compassion. Other areas have included the development of pain medicine, particularly acute pain services. Acute pain was an area, basically a large black box in healthcare in the 1980s. And it wasn't until the late 1980s and 1990s that anesthesiologists took over the treatment of patients' pain from surgeons. Surgeons were basically not terribly skilled at dealing with pain and unfortunately not very interested. Anesthesiologists, on the other hand, are skilled at dealing with pain, and most of us are very interested. We were able to change the way patients were treated postoperatively very dramatically, and that's been a very, very positive move, both for the patients and for the anesthesiologists, because it got us back on the wards. It got us back in the position of working with the staff on the wards as real participants in the larger healthcare team that cares for patients from admission to discharge. So we're going to talk a little bit now about the future. Palliative care is the care of patients who are dying. It's the process by which we try to assist people during that period of time, both them and their families. We try to help them manage their pain, manage their depression, manage their immobility. Anesthesiologists, up until very recently, were not involved in palliative care, but the work that we do in chronic pain has now shifted us over into palliative care as well. And anesthesiologists are now training in palliative care as one of the subspecialties they can enter once they've finished their regular anesthesia training. The ability to produce patient-controlled analgesia, epidural analgesia, spinal cord stimulation has improved the experience for palliative care patients. We now have ultrasound-guided regional blocks, and we can block nerves that are damaged or are causing areas of pain that is really uncontrollable in any other way. And there's an increased emphasis on trying to get away from using opiate-based drugs in palliative care patients and using drugs that don't have as much central nervous system effect so that patients remain clear-headed and are able to describe their wishes clearly to the medical team and the nursing team. Chronic pain management is also an area of basically an explosion. The need is so vast that it'll be almost impossible to train enough physicians to actually take on the load. The leaders of this process are anesthesiologists. For the last 10 to 15 years, anesthesiologists in most Western countries have worked very hard to develop chronic pain management as a subspecialty. This is modeled after the Australian model. The Australians are decades ahead of most of us in their management of chronic pain, thanks largely to Professor Michael Cousins, who is a world leader in developing chronic pain management programs across Australia, and now we try to copy him. In our other countries, we're way behind, but we're working to get there. And the impact on chronic pain management in the population is hard to overemphasize. We're going to release patients from a prison that they can't deal with, get them back into society, get them back communicating with other people, ambulating, getting out into the world, and in some cases learning to live with pain and just getting on with things. This is a huge challenge. It's very exciting, and I'm really happy that we've managed to get to this point, and I look forward to the future of improved development in this area. I'm going to talk a little bit now about something that has been called perioperative medicine. And there are different ways of looking at perioperative medicine, and what I describe as my vision is not necessarily the vision of all my colleagues, although it is the vision of many. This developed basically as a concept when we started seeing patients routinely in consultation days to weeks before their surgery. And we suddenly realized that we could take patients who had serious medical problems that weren't really recognized by the surgeon or were beyond the scope of the surgeon's skills to manage, and we can organize the care of these patients, the evaluation of these patients, and get them stabilized in an ideal position to go for surgery before they go for surgery. This has been quite a dramatic change in our practice, but it's also been a great improvement in the care of patients. And interestingly now, surgeons are very keen on the process and have found that they can depend on the anesthesiologist to do a lot of the background work on patients about internal medicine problems that need to be resolved: diabetes, heart failure, rheumatoid arthritis, a whole array of diseases that really can have a negative impact on surgery if they're not stabilized prior to surgery. So for many anesthesiologists, when we talk about perioperative medicine, that's as far as it goes for them. I see something much broader occurring. What I see is the anesthesiologist becoming the hospital physician for surgical patients, where we take care of them prior to their surgery, during their surgery, and continue to care for them after their surgery. Surgeons are extremely skilled at dealing with surgical problems. They can do the surgery and they can deal with the complications of surgery very effectively. But the majority of them are not used or skilled in treating medical problems. We are. We can bring internal medicine into the mix. They're very important as well, but they tend to be too busy to spend a lot of time with surgical patients. So they'll come and they'll consult, but they'll often not carry on with the patient. I truly believe that anesthesiologists are ideally suited as the physicians in the operating room to carry on as the post-operative physicians for patients in the hospital, and perhaps even outside the hospital in the future. That's my vision of the future. It's starting to slowly roll out in some parts of the world. I really hope it continues to roll out. I won't be around to see it, I don't think, but it, to me, is the natural progression in my specialty and the natural progression in improved care for patients. So in summary, we've had a very long course on many, many aspects of anesthesiology. I've ended this last lecture with a vision of the future and also an indication of some of the areas that we're expanding into currently. I think the future for anesthesiologists is extraordinarily exciting. I think that the need for anesthesiologists is unbelievable, particularly when it comes to pain management. It's going to be almost impossible to train enough pain doctors. I think that the future for patients will be improved by improved anesthesia care, both at the time of surgery, before surgery, and in the future, after surgery. I think this is really a very exciting vision, and it's my hope that this is the way things will develop. I hope this course has been of interest to you. You've had an awful lot of material thrown at you in a relatively short period of time. I hope you've been able to absorb part of it. I hope from this course you've learned what a fascinating area of medicine anesthesiology is and how broad its scope really is. Thank you for your attention, and best of luck in your future studies and in your future interest in my specialty.